So what exactly is MS? So MS is an autoimmune or what we call an inflammatory disorder of the central nervous system. It is the most common of disorders in this category. And if we think about young adults, so young adults, in their 20s, in their 30s, kind of the prime of life when people are establishing their careers, establishing their families, a very important time in a lot of people's lives. MS is the second cause of disability in young adults, the first being trauma and followed by MS. There are multiple types. We call them phenotypes of MS, just meaning how MS presents. MS can present in different ways. The most common type of MS is called the relapsing remitting form of MS. This is when patients come in with relapses, meaning acute neurologic symptoms followed by remission. So you can have like optic neuritis or transverse myelitis or an acute onset of neurologic symptoms. Typically, we give steroids and then, it gets better over time. Some people that start off as relapsing remitting MS over time will transition to what is called secondary progressive MS. And this means that rather than having these relapses followed by remission, patients have this slow progression in disability. It just slowly gets worse over time. Sometimes there could be relapses that are encountered within that secondary progressive phase. And then the third or the last type of MS is called the primary progressive type. Just about 10% of all MS patients have this type of MS. These patients typically do not have relapses. So they start off with just a slow progression in disability that happens over years. And, we look at their scans and we see that they have lesions that are very typical for MS, and they have those inflammatory markers in the spinal fluid. And so there are different types of MS, and this is important when we talk about treatments, because certain treatments may work for one type of MS, but may not work for another type of MS. And that's why I thought it was very important to just do a background introduction about the different types of MS. Now, a lot of times, I'm a clinician and I see a lot of patients with MS, and, when I diagnose people with MS, almost everyone asks, what caused this? Like, did I do something wrong? Did I inherit this from my parents? What exactly happened? And, how do we get MS? The simple answer is there's no one cause of MS. And we do not have, one explanation for why people get autoimmune disorders. What we know is that it's a combination of genetics. So certain genetic profiles have been associated with an increased risk for MS. And there's some kind of immune dysregulation. So for some reason, the immune system is not regulated appropriately. And then finally, a lot of environmental factors have been associated with MS. Where you live or where you grew up, where you spend the first 15 years of your life determines your lifelong risk for MS. So if you grew up in a part of the world that has a very low incidence of MS, regardless of where you move to, as an adult, your risk remains the same as where you grew up. We have other factors like vitamin D, smoking, there's a lot of research on the gut microbiome. EBV is now being looked at, and other viruses are being looked at as a potential contributor for the cause of MS. And so this is just to show us that there's no one explanation. It's a lot of different things happening together, and you have that perfect storm. You have all those factors that come together in one person, and MS happens, but we don't have one explanation for what causes MS. A little bit about the epidemiology of MS. The relapsing remitting type of MS is more prevalent in women. So if you look at relapsing remitting, 3-to-1 ratio between women to men. And then if we look at the primary progressive MS, it's almost about the same. So it's 1.2-to-1 ratio between men and women. And so, there's a little bit of a difference between those different types of MS. Now, even though MS is overall more predominant in women, from what we've learned in clinical, by seeing patients and in clinical practice, sometimes the disability is a little bit more severe in men than in women. But in general, MS is more prevalent in women, especially the relapsed and remitting type. What is the mean age of diagnosis of MS? So when is the peak of when most people are diagnosed with MS? With the relapsed and remitting type, it's about 30 years. With the primary progressive type, it's about 40 years, so about 10 years later than the relapsed and remitting type. Now, this does not mean that patients outside of these ages cannot be diagnosed with MS. I've diagnosed 16-year-olds with MS, and in the same vein, I've diagnosed 60 or 65-year-old patients with MS. It's a little bit more challenging because we want to make sure that it's not something else going on, but sometimes people feel, I don't fall in this age group, therefore it can't be MS. And you do have MS diagnosed in other age settings. This is just the most likely age of diagnosis. And then we have isolated multiple genetic subtypes that are associated with MS. The first, the HLA-DRB1, the 1501 haplotype, that's just the most common genetic profile that has been associated with MS. And we know by twin studies that monozygotic twins, meaning identical twins, have a 30% concordance rate, meaning if one of them has MS, there's a 30% chance the other one will eventually be diagnosed with MS. However, if you look at dizygotic twins, these are twins that are not identical, it's just 5%. So that tells us there's some kind of genetic marker, but it's not 100%. Because if it was 100% genetic, if your identical twin has MS, then that other other sibling should have MS as well. And then the other factor is if a person with a first degree relative with MS, meaning father, mother, or siblings, has a 20 to 40-fold increased risk compared to somebody that has no family member with MS. So there's a clear genetic susceptibility, but it's not an inheritable disease. The prevalence of MS in the US, this was a study that was published a few years ago, and we found out that there's a lot more MS in the US than we previously thought. Almost 1 million, or about 1 million patients all over the US. There's a latitudinal gradient, meaning people all the way in the Northeast have a higher prevalence of MS, that's 377, and that prevalence goes lower as you come down towards the South. So it's 377 and then 353, and then you have 272 and 272 in the West and in the South. And so this has not only been seen in the US, but in other parts of the world. The closer you go to the equator, the lower the incidence of MS, or the lower the prevalence of MS. And we clearly see that in the study on the MS prevalence. Okay, let's talk a little bit about the disease-modifying therapies of MS. These are the treatments that we use to prevent relapses and to prevent progression over a long time in patients that have MS. And I put up this slide just to show us how active the research in MS has been. So the first drug for MS was approved in 1993. And that was a beta seron. It's an interferon beta. And since then, we have multiple drugs that have been approved. This actually goes on to 2020. So, we have a lot of the injectable treatments, the interferon beta treatments like beta-seron, Avonex, glatiramer acetate, also known as the brand of this Copaxone, also came out in the 90s. Mitoxantrone, which was used for secondary progressive forms of MS. That it's not heavily used right now, but it was approved in 2000. Natalizumab or Tysabri, which is an infusion that is still being used for MS, was approved in 2006 or reapproved in 2006 because it had to be taken off the market after PML was associated with it. But we have a bunch of oral drugs, fingolimod, which is Gilenya, teriflunomide, which is Aubagio, dimethyl fumarate, which is Tecfidera, and then a lot more that have come out more recently. We also have other infusions like ocrelizumab or Ocrevus, alemtuzumab or Lemtrada. So, there's been a lot of research in MS. We have, a lot of drugs that have been approved between 93 and, it's 2022 right now, but this slide goes to 2020. And this is just to show us that, there's a lot of research that has gone into MS. There's a lot more research that's going into MS treatments at the moment. This is just another picture showing us the different types of treatments. The injections are up here. We have the pills, a lot of people take the oral treatments. We have infusions, and even with the infusions, we have, the B-cell depleting drugs. We have Tysabri or natalizumab, and then we have other drugs that work in a slightly different way. So we're in a time where there's a lot of different options. I still have patients today that were diagnosed with MS in the 70s, in the 80s, and at that time, they were diagnosed and their doctor just said, we hope it's a good kind of MS because we really don't have any treatments available. But this is a time where there are multiple, almost 20 different drugs and brands of drugs that can be used for MS. Now, within the last few years, there have been a few new drugs. For instance, ofatumumab, also known as Kesimpta, was approved within the last few years. And then there are other emerging drugs that haven't been released into the market yet. And that is what I want to talk about today. Those drugs that are still in studies, are still being researched, and someday may become MS drugs that your doctor can prescribe and you can start getting. So we're going to talk a little bit about some of these drugs. And we're going to start with oblituzumab. So oblituzumab is a new infusion that, the phase 3 trials were just completed. This is an infusion that works very similar to ocrelizumab. Now, a lot of people are familiar with ocrelizumab. It's an infusion that's given every 6 months. It depletes a subset of cells called the B cells. And this drug works very similar. It's kind of a very similar mechanism to ocrelizumab. The phase 2 trials, this is a picture showing us what the phase 2 trials looked like. We had a 95% reduction in the rate of relapses. Now, that's a very good outcome when we look at how much reduction there was in the rate of relapses. There have been phase 3 trials going on. We don't yet have the official results, but the phase 3 trials have been done, and very soon, this is going to go to the FDA for approval. If it probably has gone in already, and once, it has gone through, and if the FDA approves it, this will be another option that we can use for MS that works very similar to ocrelizumab. Okay. Now, another set of very interesting drugs. This is a different set of drugs. They're called the BTK inhibitors. Now, this is a new type of concept because we have not used these in MS, these types of drugs in MS before. There are multiple different types that are being studied in MS, and I'm going to talk about a few of them. Now, what exactly are these drugs? So BTK stands for Bruton's tyrosine kinase. It's an enzyme that's found in certain immune cells. So the BTK inhibitor drugs, they inhibit this enzyme. So, for instance, you have this BTK enzyme in your B cells, in the myeloid cells, and also in what we call microglial cells that are in the brain. These are immune cells in the brain. And the BTK inhibitor drugs act not just on the peripheral circulating immune cells, they also have impact on the immune cells inside the brain or inside the nervous system, which is very unique because a lot of the other drugs we have an effect on the peripheral immune system, meaning that immune system that's outside of your brain, trying to prevent it from, getting into the brain. Um, these drugs are not brand new drugs that have never been used before. They have been used for certain kinds of leukemias or lymphomas in patients that have transplant to prevent graft versus host disease. And then some of them are used in things like lupus or other autoimmune diseases. And so that's a good thing because we know what the safety of these drugs are because they've been used for other disorders before. Now, what are the potential advantages of these new set of drugs for MS? Well, they have an impact on different types of immune cells, both the B cells, which are under the immune cell called the adaptive immunity, and also what we call innate immunity, which would be the CNS resident cells, which would be the microglia. As I also mentioned in the last slide, these drugs have been designed to actually get into the brain, and they have an effect on the immune cells in the brain called the microglial cells. And so there's a lot of hope that this would have a neuroprotective effect. This would have some kind of an additional effect than we expect from the traditional drugs we use today, because most of them affect your immune cells outside of that CNS environment. These drugs are being studied for both relapsing types of MS and progressive types of MS. And that's a very good thing because, as most of us know, there's not a lot of drugs for progressive MS phenotypes. And so if this is a positive, if we see some benefit, it's going to be a very huge thing, especially, for everyone, but especially for people with progressive MS phenotypes, because we do not have a lot of options. The preliminary studies were very good. So the animal model of MS is called EAE. These are mice that, have been treated in some way to have a type of disease that looks like MS. When this drug was administered, it actually prevented or treated that experimental form of MS in mice. There have been a few phase 2 studies, and I'm going to talk a little bit about those phase 2 studies that showed significant and clinical results that showed possibility of having a good effect in treating MS. One of these drugs is called tolebrutinib. This is the phase 2 study in relapsing remitting MS. And what we found was they looked at different doses of this drug compared to placebo. Placebo meaning it's just a sugar pill, it's not a real drug. And we clearly see that at the 60 milligram dose, relapses were all the way down, or the number of new lesions were very, very low, but placebo had, a lot of new lesions. So we can clearly see that this was a dose-dependent effect, meaning the higher the dose of the drug that was used, the better the outcome in reducing relapses. The same thing with, the new T2 lesions, and this is enhancing lesions. So those active lesions that come up when we compare placebo or lower doses of this drug, the 60 milligram dose was very effective in suppressing inflammation. We didn't see as many relapses in that subgroup. The drug, it's an oral drug, it's a pill. You take it, in this study was once a day. For this drug in specific, it was very well tolerated. Not a lot of risks, not a lot of issues occurred because, due to the medication. And this is another different study. This is another variation of the BTK inhibitor called Ibutalast. And this is another phase 2 study that was designed. And same thing, we found out that the 75 milligram dosing, we looked at different doses. That's placebo, that's, a small dose, that's 75 milligrams daily, 75 milligrams twice a day, and that's dimethyl fumarate or Tecfidera. And what we found was there was a reduction in the number of lesions, mean number of lesions, and the annualized relapse rates. So the phase 2 studies showed promising results. This was looked at over a 12-week period, 12 to 24-week period, and it was a positive study in relapsing remitting patients. And so right now there are multiple studies going on for BTK inhibitors in MS. We talked about two of these, the tolebrutinib and evobrutinib. There's also another one called fenebrutinib. In our institution, we actually are doing trials. We are a site for these studies, and I'm actually the principal investigator for both the relapsing and there's a relapsing primary progressive and secondary progressive arm of phase 3 trials going on right now. And so based on the results we get from these studies, hopefully within the next few years, we will be able to determine if these are effective drugs for relapsing MS, primary progressive MS or secondary progressive MS, and that would give us a lot more tools to use for our patients. And this is oral, it's, not an injection. We don't need to send people to the infusion center. So there are a lot of advantages, if any of these drugs become approved for MS. Okay, shifting gears a little bit, this is another drug called Ibutalast. This is also an anti-inflammatory drug that inhibits an enzyme called the phosphodiesterase 4. It's actually used in Asia, in Japan, to treat asthma. And there was a phase 2 study that was done in MS, some time ago, and it didn't really prevent relapses, but we noticed that it slowed the progression of brain atrophy. Atrophy just means brain shrinkage. And we know that people with MS have an accelerated rate of brain atrophy. We all, as we age, lose some mass or volume in the brain, but that is, in MS patients, that rate is accelerated. So they noticed that, when they tried this drug in relapsing MS, it didn't really prevent relapses, but it slowed the rate of atrophy. And so there was another trial that was done that looked at progressive types of MS and compared Ibutalast to placebo. And in that phase 2 study, what we found was that Ibutalast was associated with a slower progression of brain atrophy. And I've put some of those results here where we can see that the patients on Ibutalast had a less, the rate of atrophy was not as fast as, the patients on placebo. So we need more studies. We need probably another we need a phase 3 study to look at it, properly, to see if this is actually something that we can use for patients with MS. And in this study, the interesting thing was that patients that were on a disease-modifying treatment, the injection treatments, were allowed to do this study. So maybe this could be something that could be an add-on therapy, because it may not reduce relapses based on what we saw in the previous trial, but it may slow the progression of brain atrophy. So this may be like an add-on therapy that we do to the disease-modifying drugs that prevent relapses. But more studies are needed, more evidence is needed. What are some of the side effects that were noticed? GI side effects, meaning gastrointestinal side effects, headache and depression. Those were the side effects that were some of the side effects that were noted in the trials. This is another drug called Masitinib. This is being looked at for progressive MS. This is also an inhibitor of a tyrosine kinase enzyme. It downregulates, or it inhibits this enzyme in the mast cells and the microglial cells. Similar to the BTK drugs, this is going to work on the microglial cells. And the main question is, can this drug slow the progression of disability in patients with primary progressive MS? This is one of the studies that was done. It was just published not too long ago, a few months ago, and they compared the drug versus placebo, the Masitinib at a specific dose versus placebo. They looked at primary progressive MS and non-active secondary progressive MS, and we saw some benefit, meaning when we look at the change in the EDSS, which is a disability scale, patients on this Masitinib had a lower change in EDSS, meaning the patients on placebo were more likely to have a change in EDSS or become more disabled compared to the patients on the real drug. More studies are needed to validate these results, but another promising drug that could be available someday for patients with progressive types of MS. And then just a few words about this anti-LINGO, also known as upisinumab. And this is a very unique concept. So this drug was looked at to see if it could initiate remyelination or promote remyelination of neurons. I'm sure we all know that, or some of us should know that MS causes demyelination, meaning that fatty insulating layer around the nerves are stripped off by inflammation. And there's always been questions about how can we help those nerves to become remyelinated? How can we help them to reform that myelin? And this drug was studied specifically for that. There was a phase 2 study that looked at the drug in patients with optic neuritis. There was some promise. It looked like it was a potential, there was a small but significant improvement. Unfortunately, when a phase 2 study was done in relapsing MS and secondary progressive MS, it was a negative study, meaning the drug did not show any significant improvement. There may be more trials that come just to see if there is any hope of using this drug in the future. But the more recent study that was done was a negative study. But we still do not have medications that can promote remyelination in MS. And I wanted to, even though this was a negative study, I just wanted to put this on to say there's a lot of research. We're looking at MS from different angles. We're looking at MS from, can we manipulate the immune cells? Can we manipulate the immune cells in the brain? And can we repair the damage that has been done? So those are all different types of research that's going on. Okay, so we're shifting gears a little bit. We're going to talk about stem cell transplantation. People always have a lot of questions about this. And I'm specifically talking about autologous hematopoietic stem cell transplantation. So this is a very unique treatment. It's typically used in patients that have certain types of blood cancers like leukemia or lymphoma. Certain types of cancers for many years have been treated this way. So the idea is that it tries to reset the immune system in some way. And I have another slide that kind of puts a picture of what happens during this procedure. Um, at this point, we know that, and this is just an abbreviation because it's a very long word. This type of stem cell transplantation is a good treatment for patients that have very aggressive relapsing remitting MS, meaning they have many relapses, they're not been, they've been on multiple disease modifying treatments, effective disease modifying treatments, and have not really gotten better. This is a good treatment option. This is a one-time procedure, and I'm going to show us another slide of what happens during that procedure. The studies that have been done have been really, really good. There's been a significant reduction in reducing that inflammatory activity that we see in patients with relapsing MS. However, there are certain risks that can come out of this. There is the risk of infection. We're going to talk about some of the trials where, a few people died during some of these trials. And so this is not a trivial treatment that we don't have. I mean, this is something that's gone into with a lot of thought. And so far, it is still in studies. It's not an FDA-approved method of treating MS yet, but there's studies that have been done and studies that are going on now that I'm going to talk about. Okay, so what exactly is this treatment that I'm talking about? And I'm going to take us through this diagram and hopefully get everybody, some understanding of what happens. So what happens is, first of all, the patient, so this is we're talking about a patient that has MS. We administer a pre-treatment to release stem cells from the bone marrow. Now, what are stem cells? Stem cells are just the cells, the cells in the bone marrow that that become evolved into other immune cells. And so these are the cells at the very proximal end of where they have not differentiated yet to different immune cell types. So you get a medicine that helps to release those cells from the bone marrow into the circulation. And then there's a blood transfusion that's done, or some kind of blood collection that's done. We take the blood from the patient after they have been released from the bone marrow, and we store those stem cells. They're frozen, they're kept somewhere very safely to be used later. And the fourth step is we administer very strong chemotherapy to ablate or to remove the immune system that's left in the patient. So we're harvesting the stem cells, we're storing them. After we've harvested them, we give the patient, or the patient is given very strong chemotherapy to wipe out or to remove the remaining remaining immune cells in that patient. And then after that is done, we take these frozen stem cells we harvested, the cells are thawed, and then they are re-injected into the patient. And then after that, the patient needs to be monitored very closely. It says at least 4 weeks. We're giving you a lot of supportive treatments to make sure that, that patient is tolerating these cells really well. And that is what the treatment looks like. So we harvest stem cells from the same patient. Autologous means it's the same patient. We're not giving you stem cells from somebody else. We're using that patient's stem cells on themselves. But the idea is that these stem cells have not really been triggered to cause MS. And so once we harvest these cells, we eliminate the immune system that's in the patient, not completely eliminate, but we kind of remove or reduce that residual immune system that's in the patient, hoping that those cells that are triggered to cause MS are being downgraded. And then we give back the stem cells into the patient. And a lot of studies have shown that patients have responded very well. patients with highly aggressive relapsing remitting MS. So that's what the procedure looks like. This is a table that just shows us different trials that have been done for this procedure. The data we have, a lot of data we have is from the Canadian report, 26 patients, 24 received a transplant. Very positive outcomes of these patients, meaning they came out of this and really had a reduction in their relapse rates. Most of them don't need to be on an MS treatment after this procedure. But I want us to be, look at this mortality. So a few patients actually died. And so this is not something that we just do, anyhow. We have to do it very thoughtfully, because there are a lot of risks to doing a procedure like this. There are many other studies, or a few other studies that have been done, most of which have shown some degree of positive outcome for patients that undergo this type of procedure. Right now, what are the studies going, what are studies that are currently enrolling? We have a study called the BEAT MS clinical trial. This is funded by the NIH, the National Institute of Allergy and Infectious Disease. That's the sponsor of the study. And basically, this study compares high dose immune suppression followed by the autologous hematopoietic stem cell transplant. We're comparing it to the best available therapy, meaning the treatment is going to randomize some people to get the stem cell therapy versus best available MS therapy. And hopefully at the end of this study, we will find out if doing this procedure is better than just doing a regular MS drug. The participants are being followed for 72 months after randomization. So this is a pretty long follow-up, after they have been randomized to get the treatment. Now, who is an appropriate candidate for this type of procedure or this type of treatment? Now, so far, the data we know is it's effective in patients with relapsing forms of MS, meaning you have the patient that has relapsing remitting MS. And the patient has not benefited from the current therapies that are in the market, meaning you've been on the very effective therapies, but these patients are still having relapses despite being on the highly effective therapies. Patients younger than 50 years, we're more likely to have a good outcome, so 50 years or younger. Typically, we also want patients that don't have a lot of other comorbidities, meaning there's no, if the patient has multiple, diabetes, hypertension, heart disease, or other types of disorders along with MS, it makes it a little bit more tricky because there are serious risks to doing this procedure. The studies also showed that patients that had a shorter duration of disease, so were diagnosed with MS less than 10 years ago, were more likely to benefit from this procedure. What is the cost? The estimated cost of a procedure like this? It's about $150,000 to undergo this procedure, which sounds like a lot. But if you compare that to how much we pay each year for an MS treatment, and this is a very rough estimate, and most MS DMTs are very expensive. The estimated annual cost is about $80,000 or more. And so we're looking at a one-time cost of $150,000 versus we're shelling out about $80,000 every year for many, many years. And so in the long run, this may be a cost-effective way to manage MS. As I said, this is still in the trials. It's not something you can just go to a doctor now and ask to get it, but we need more evidence, we need more data before this becomes mainstream approved for treating MS. Now, the National MS Society has certain recommendations about hematopoietic stem cell transplant in MS patients. And I'm just going to go through some of them. So, the recommendations are that this should occur at a center that has a lot of experience and a lot of expertise in treating patients with MS and in also performing the stem cell procedure. And then people treated MS patients should every patient MS patient that's undergoing this procedure, they want you to enter into a database so that we get a lot of data or a lot of information about how this treatment affects patients that have MS. More research is needed. We need more data and more evidence to know what is the best protocol, what is the best standard for cell mobilization and immune conditioning regimens. And then we need more studies to compare this type of treatment, the hematopoietic stem cell transplant, with highly effective disease-modifying drugs, which is what the BEAT MS study is doing. And this is important because, as we said, this is a very, very intensive procedure. Now, if we want to undertake it, what advantages does this have to a very effective MS treatment? Because, there are treatments today used for MS that are very, very effective in slowing the disease or reducing relapses. And so if there's a treatment that is effective but has a lot of risks, we always want to know, how do we balance those risks versus benefits? And so this is something that, may be very promising, in the future as we get more data. And, I've had a lot of patients that, have been approached by different people or even going to other countries to get stem cell transplant. I always talk to my patients to be very careful. At this point, this is not an FDA approved treatment, but hopefully very soon as we get more information, we will know and we will have a standardized protocol, hopefully, to be able to use a treatment like this. All right, so we've come to the end and we have a few minutes for questions, but this is a summary of what we covered. There are multiple trials going on for both relapsing forms of MS and progressive forms of MS. We talked about a few of these trials. We talked about the autologous hematopoietic stem cell transplant as a promising treatment for patients with the relapsing forms of MS. And there's a big trial that's going on now, and hopefully we're going to get a lot of information from that trial. And on the other hand, we see that there's a lot of needs in MS management. We don't have a lot of drugs that have a neuroprotective effect. We still don't have any drugs that promote remyelination. We don't have a lot of options for patients that have progressive MS, whether it's the secondary progressive type or the primary progressive type. I mean, the secondary progressive type, we divide that into secondary progressive with activity or secondary progressive without activity, but just not a lot of treatments that can slow that progression that we see in patients with progressive MS. And then we don't have any restorative treatments, meaning how can we help patients regain function that they've lost? Most of these treatments help to prevent relapses or prevent the progression of disability. But how about patients that, have had a lot of disability? Are there any treatments that we can give them to recover? At this point, we do not have a lot of we don't have any treatments that can do that. So there's still a lot of research that's going on. We have a lot of really smart, really great scientists that are looking into this, and we're hoping that someday we have options to give our patients, to not only to prevent relapses or to prevent, progression of disability, but to remyelinate those demyelinated neurons and to restore function that has been lost. So we're hoping that as more and more research is done, we're going to get more answers and we're going to improve the quality of life of patients with MS. So this is the end of the presentation. I really want to thank you for listening. I think I'm going to call Aaron back up because he's going to moderate the questions, and we can go over any questions that came up.
Fantastic. Gosh, that was so insightful. Thank you so much. Now, for our audience, we are ready for questions. If you have a question or comment, please use the raise hand feature in the app, or you can send your question via chat. We do recommend that you utilize the Q&A function if you want to stay anonymous. Just to let you know, to raise your hand, if you want to ask a question via your own voice, click the screen to pull up the menu, select more. It's under the icon with the 3 dots, and click raise hand. And I will unmute you, and then a button will appear on your screen asking if you want to allow me to do that, and then select allow. Okay. So with that being said, we have many a question to ask. So the first one, I want to start off with Janet, and she asks, what do you consider young adults? And she put young in quotations.
Young adults, I think I mentioned that when I talked about disability, MS being the second cause of disability in young adults. I don't know that there's a specific classification, but I would say individuals in their 20s, in their 30s, 40s, those early stages when we're still, establishing ourselves, whether it's in a career, whether it's in a family, that's the second leading cause of disability. As people get older, other causes of disability come up, more having to do with comorbid medical conditions. So I don't know that there's an official definition, but we're talking about people very young that don't have a lot of have not acquired a lot of medical comorbidities.
Okay. Wonderful, thank you. So our next question actually comes from Facebook, and Helene asked, are all those DMTs something that lowers the immune system?
That's a very good question. So not all DMTs are immune suppressive, but most of them are. And most of the effective DMTs are immune suppressive. The injection treatments or the injection therapies like glutamate acetate or interferon beta, we tend to not think of them as immune suppressive because they do not reduce any of the immune subcells. But most of the more effective treatments are definitely immune suppressive to some degree.
Okay, awesome. So I'm going to take a question from Terry. Oh, looks like Terry has lowered her hand. All right, so we'll go with Vincent, who has his hand raised. I'm going to allow you to talk. Vincent, are you there?
Yes. Hello?
Yes.
Can you hear
me? We can hear you.
Yeah, I just wondered if you can talk a little bit about mesenchymal stem cell research and what's going on with that.
Mesenchymal stem cells, so that's a slightly different type of stem cells, and there's not a lot of evidence that that is effective in MS treatment. And so the hope for that type is, can we have some kind of restoration? That doesn't typically focus on your immune system, but more on, can we cause some kind of restoration of damage to the nervous system? There are some studies, I think that's a little bit further out, and we don't have any major studies that have shown that that's something that would be very beneficial. Whenever we inject, there are studies that have looked at injecting some cells into the brain or, into the nervous system. We always wonder about malignancy. Like if you're putting a stem cell in an organ, that could trigger it to just replicate in a way that could cause cancer. And so not as many studies. I think there's research going on, but the data on that is a little bit further out than we have for the hematopoietic stem cell transplant.
Thank you.
Wonderful. Okay, so we're going to keep this moving, and we are going to have Danielle ask, can you take BTK medication as the Rituxan infusion?
So can you take them together? Is that the question?
I'm going to assume yes, but Danielle, if for whatever reason that is not specifically what you are asking, please write it in the chat.
So far in the studies, we're just taking patients on the BTK inhibitor drugs. We typically do not combine with any other treatments. If you are on rituximab or any other MS medications, you would have to stop and you would have to actually have a washout, meaning have a washout of that drug from your system before you can go into the BTK study. Generally in MS, we do not combine different immune suppressive treatments together. And at least for the study, we're only studying the BTK inhibitors, because if you're also on rituximab, we don't know if the effect is from rituximab or from the BTK inhibitor. And so for the studies, it's plainly just a BTK inhibitor, and there's no combination treatment.
Okay. And that was specifically what she was asking. So thank you so much. All right, we're going to move on with Joy. And Joy asks, over what period in the course of MS is the efficacy of AHSCT most effective?
Very good question. So as we said, the hematopoietic stem cell transplant is most effective very early on in a relapsed and remitting patient. The new article that came out not too long ago said most of the time, or most effective in patients within a 10-year window of their diagnosis or onset of symptoms. And so this is a treatment that's good for patients that are early on in that diagnosis and they haven't really set up a lot. We haven't had a lot of disability accumulation yet. And as I said, relapse and remitting MS, the studies haven't shown any significant promise for patients with progressive types of MS, whether it's primary progressive or secondary progressive. So early on relapse and remitting MS within the first 10 years of diagnosis or symptom onset, that would be the answer.
Fantastic. Okay. And we're going to move over to a phone call. This is Terry. I'm going to allow Terry to talk. Terry, can you hear us?
Yes. Can you hear me?
We can hear you.
Yep. I got detained and came late, and I noticed your recording. How can I re-listen to the seminar?
Oh, no, that's going to be no issue whatsoever. We are recording this as we speak, and it will be going up live on our YouTube channel within the next 2 weeks.
Okay, great. Thank you very much. Is OSU Oregon or Oklahoma or somewhere else?
Ohio State University.
Ohio. Okay, thanks.
Yeah, it's in Columbus, Ohio.
Okay, thanks for your time.
All right. Fantastic. All right. We are going to move on to Katerina. And she asks, has the impact of these new drugs on progression towards disability been studied beyond the reduction in the number of lesions?
That's an excellent question. So far, we don't have data yet, but at least 2 out of those 3 different BTK inhibitors are being studied in progressive MS phenotypes. And so, we have studies going on primary progressive MS and secondary progressive MS for those BTK inhibitors, but we don't have any preliminary data of how these drugs affect progressive MS phenotypes yet. That's a very good question.
Okay. And we have another question. Is there a max age for AHSCT?
There is no maximum age. I mean, and as I said, this is still being studied. The new article that came out from the National MS Society, the data, when we look at all the trials, people that are less than 50 are more likely to have a positive outcome. And so it's not like 50 is not like a magic age, but the recommendation is we want this to be more considered in people that are younger than 50 years old. Now, as we do more studies and we get more information, I know that the BEAT MS trial is looking at patients between 18 to 55. And so we're going to get more data on just different patients. And if we see that, people older than 50 do well, maybe that recommendation changes. But at this time, the recommendation is to consider it in people 50 and younger.
Okay, wonderful. Okay, this is a two-part question from Danielle, and she asks, how long is the stem cell procedure, and how can you sign up to be a stem cell candidate?
That's a good question. So if you there's actually a website for the Beat MS trial, and you can Google it. If you Google Beat MS, that's BEAT/MS. It's a clinical trial. You can actually find out all the sites. There are multiple sites in the US, and I think there's even a site in London and outside the country. So it will have to be, you can find out from any of these sites if you have one that's close to you, and just call them and ask, are you still enrolling for this clinical trial? Can you, is this something that I can be evaluated for, or how does the procedure work? But I know many centers that are still enrolling, but there's an eligibility criteria, and you would have to meet that eligibility criteria. So most centers are going to take you through that and let you know if you're eligible or not. But you can find that information on the website. And what was the second part of the question?
The second part of the question was, how can you sign up to be a stem cell candidate?
You would have to call the centers that are participating in the trial. Yeah.
Okay, wonderful. All right, so this question is from Sylvia, and she asks, in the table with the AHSCT studies, there was a 5-year survival rate mentioned, generally of 69.9%. Does this mean that almost 30% of people did not survive more than 5 years after?
No. Let me see if I could pull. Let me just share my screen again, because I think it just makes the most sense. Okay. So, and the question, what was it? Can you repeat the question?
I can. Give me 1 second. In the table, so we're in the table, there was a 5-year survival rate mentioned, generally of 69.9%. Does this mean that almost 30% of people did not survive more than 5 years after HSCT?
Yeah, that's a good question. So the mortality is kind of all the way on the last column, and this is telling us were there any deaths in the trial. Other than this first one, which is a Canadian trial that had a 4.2 mortality, all the others did not have, there was a 0 mortality, meaning there were no deaths. And I think what happened is we learned a lot from the Canadian study on the type of chemotherapy regimen that's given, and the protocol was tweaked a little bit after those early deaths happened. And the newer protocol, there's been a lot less mortality with the newer protocol. I'm not sure. I think this is event-free survival, meaning not having more events like MS relapses or any events related to MS. And this is not a mortality survival, but more mortality is kind of at the end over here on the table. So great question.
Okay. So we are bumping up at 4:30 right now. Dr. Gyang, do you have time for a few more questions?
Sure.
Wonderful. I'm sure everybody very appreciative of that. So we have a question from Glover, who asks, how does Mavenclad compare to impacting relapses and remissions of, and I'm so sorry, you'll have to excuse me as I try to pronounce this, UBIOLITAFYMAB.
Oblituzumab, is that what?
Yes, that is what that says.
Sure. So Mavenclad is another MS approved drug. I think if I remember correct, in the trials, it reduced relapse and remitting annualized relapse rates by about 58%, which is a good number. Like, it's classified as a highly effective treatment. It has not, at least from what I know, it has not been compared to oblituzumab. Oblituzumab is that new drug that we talked about that is coming out may be coming out very soon. We do not have a head-to-head comparing oblituzumab and Mavenclad. And I checked right before this lecture, we don't have the phase 3 results yet for oblituzumab. The phase 2 was very promising. There was a 95% reduction in relapse or new lesions, but I don't have the annualized relapse rate reduction in the phase 3 yet. So the answer is there's no head-to-head between Mavenclad and Oblitizumab, but Mavenclad reduced annualized relapse rates by about 58%, and then we'll see how well the Oblitizumab reduced relapse rates. In general, we can't compare two separate trials. We can't just compare those numbers because they're different trials. There's different criteria for the different trials. So it's hard to compare two separate trials and say, how do these numbers compare? Without a head-to-head, meaning compare Mavenclad and Oblitizumab, it's hard to say if one of them would be better than the other.
Okay, wonderful. And actually, since we are on the subject, can you explain from, this is a question from Bettina, and she wants to know, what are the side effects of
Oblitizumab?
Of the medication that you just spoke of?
Okay, good. So side effects, or, we talk about risks and we talk about side effects. Side effects would be, how you feel when you take the medication. So it's an infusion, they put it in an IV, very similar to ocrelizumab. With any of these infusions, you could have a reaction during that infusion, and the reaction could range anywhere from, having hives, changes in your blood pressure, to having an anaphylactic reaction, which is rare. Most people do not have that. Most people tolerate, infusions pretty well. Now, what are the risks? The risks have to do with the fact that it suppresses your B cells. And so there may be an increased risk for infections. We talk a lot about upper respiratory tract infections. The other things we see with the B cell depleting drugs is that you may not respond robustly to vaccinations. And that's kind of a big issue in the era of COVID, where we're having a lot of people getting vaccinated. And then theoretically, we always are vigilant about malignancy, because your immune system also helps regulate or prevent malignancy. So we always advise our patients to make sure they're keeping up with age-appropriate malignancy screening. Mammograms, colonoscopies, pap smears, all that you want to make sure you're keeping up with. So there are side effects from getting the infusion that could happen, that, a lot of times we give a little bit of steroids while the infusion is going on to mitigate some of those risks, the side effects. And then overall, there are certain risks with doing any of these treatments because they're immune suppressive.
Fantastic. Okay. And this question is from Vincent, and he asked, can you talk about mesenchymal stem cell research?
I think we answered that already earlier on, and the simple answer is it's still a little bit, we still need a lot of data. There's not a lot of data on mesenchymal stem cell research at the moment. Most of the research looks at how we could remyelinate neurons, how we could create stem cells that eventually become oligodendrocytes that cause remyelination. I'm not aware of any trials that's actually taking people right now to look at how we could do that. And as I said, there's a lot of concerns when we start doing things like that, because, there are trials that have looked at injecting some of these cells into the nervous system, but there's a lot of risks. If you put in a stem cell, it has the potential to evolve and to replicate into cancer. And so, we're very careful about that. My patients always ask, there's a lot of offices that claim stem cells. You want to be very careful with doing things like that. But so far, not a lot of data yet, but hopefully more to come in the future.
Okay. And we'll have time for 2 more questions. This question is from Alicia, and she asks, once the stem cell transplant is approved by the FDA, how quickly will it take for the insurance company to cover it?
I hope immediately, but, once it's approved, I'm hoping that most of them see that this is actually cheaper than paying $80,000 every year on a disease-modifying treatment. So I don't have an answer to that question, but I hope that as soon as it is approved, most companies will have some kind of criteria or guideline to approving this procedure. But if it is approved, and I feel like if your doctor recommends that that's a treatment option, I feel like it should be approved, but that's a question for the insurance companies. And there's a cost efficiency with doing this procedure, because you're doing a one-time procedure. The cost is upfront, but you're saving that annual cost where you have to do a disease-modifying therapy every single year. So I think if they're smart, they should approve it right away. But I really don't control how they approve their drugs. And I'm always, on the end of fighting with them. So I hope that they don't give a fight.
Okay, and this is going to be the last question for this session. And this is from someone who asks, is there a time when patients should stop taking DMT?
Very good question. And the answer is probably yes, but we do not know when. We don't have a test or a procedure. We don't have a way, a biomarker that tells us when inflammatory activity stops. And I'm talking about a relapse and remitting patient in this case. There's a study that's actually going on now called the DISCO MS study that's actually trying to answer that question. But the natural history of MS, we know early on when you're diagnosed with MS is when a lot of the inflammation comes on. So patients have a lot of relapses early on. But as you get older and towards the later portion of the disease, inflammation quiets down by itself. And at some point, we don't need to keep those disease-modifying treatments on. But we don't know, we don't have a test or a good way to know. And the only way sometimes we do it is doing a trial of a disease-modifying drug. So typically, if you're in your 60s or you've had MS for a very long time, you've been stable for many years, you could talk with your doctor. Sometimes you would do, a trial off where, you get a baseline MRI. And if you stop the drug, you get MRI scans, 6 months, 12 months, you kind of get MRI scans to see if there's more inflammation and you get monitored in that way. But we don't have data. And there are people that believe you should be on a disease-modifying treatment, indefinitely. And, we can't really say that's wrong because we don't have data at this point. But generally, inflammation quiets out by itself. And there are patients that are able to successfully get off a disease-modifying treatment. But I've had patients at 70 that are still having relapses. Everybody with MS is different. In some cases, most cases, you're able to get off a disease-modifying drug, but, there are cases where it's just not letting up and you're given very aggressive treatments, even when patients are in their 60s or in their 70s. Yeah.
Okay, fantastic. And I just want to let everyone know for those who had additional questions and might not have been able to get them answered today, you are in luck because our next town hall Q&A with Dr. Ben Thrower will be on June 14th at 3:30 p.m. And you can see in our chat that there is a link to sign up. With that being said, that's all the time we have for now. If you missed any part of this conference, it will be replayed on msfocus.org and available on demand, or on our YouTube page within 2 weeks' time. Remember to follow us on Facebook, Twitter, and Instagram for times and access info. And I'd like to let you know our next teleconference will be Building a Stronger MS Community on Monday, May 23rd at 3 p.m. Eastern with registered nurse Sherry Binns. Our sincere thanks to all of our attendees for your participation, and especially to Dr. Gyang. Thank you so much for your time, and thank you so much for your time. We really truly appreciate all this information. I want to really thank you, and have a great rest of your day. Goodbye.